So this is one of the important aspect of infertility evaluation. We understand that fertility is something related with both the partners, like male and female, and the male partners constitute almost the equal weightage into the management and evaluation. So these are the topics which we are going to cover in our lectures, which include introduction, causes. We will be discussing the evaluation of infertile couple as well as the management part. So by definition, if we go, it is defined as failure to conceive after 1 year of regular unprotected sexual intercourse. It's a standard definition given in all the books. If we go by the prevalence and etiology, prevalence of etiologies in cases of infertility, the male factor contributes around 20 to 30%, while female factors are around 40 to 55%. While in 10 to 40% of the cases, both the partners are equally responsible. While in certain 10 to 20% cases, we really don't know why the couple is having infertility. So if we go into the causes and discuss in details, so male infertility causes are divided as, these are common causes. You can say that hypothalamic pituitary disorders constitute around 1 to 2%, while the primary gonadal disorders constitute major bulk of 30 to 40%. Disorders in sperm transports is responsible for around 20% of the causes, while 40 to 50% cases we really don't know why the male factor problem is there. It's a standard reference from Spear of 8th edition. So there is another way of classifying the causes is pre-testicular causes, testicular causes, post-testicular causes, and sperm transport defect. Let me be very clarify that this is the testicular areas. So causes which are related to above this, it's like brain, central causes, endocrine causes are all comes under pre-testicular causes. While the testicular causes are something which are located inside the testes, and post-testicular causes are the one which are lying in the ejaculatory duct part, in the penile part, and another causes of sperm related causes we will be discussing into the details. So pre-testicular causes, endocrine, hypogonadotropic hypogonadism, that means the pituitary itself is not able to produce the hormones. Hypothyroidism, hyperprolactinemia, common causes. Coital disorders again comes into the category of pre-testiculars, which include erectile dysfunction, impotency, ejaculatory failures, impotency, psychosexual problems. There are certain drugs also which are responsible for male factor infertility, like sulfasalazine, nitrofurantoin, chronic uses, chemotherapeutic drugs. Anti-androgenic effect of cimetidine and spironolactone are also known to cause such type of problem. While erectile dysfunctions are commonly associated with beta blocker, thiazide, diuretics, and metoclopramide types of drug. Misuse of anabolic steroid, heroin, cocaine also is responsible for male factor infertility. In testicular causes, common causes are genetic causes like Klinefelter syndrome, Y chromosomal deletion, immotile cilia syndromes. Certain congenital problems like cryptorchidism and infective pathologies are responsible for testicular causes. Anti-spermatogenic agents like heat, chemotherapy, and irradiation are responsible for testicular causes, and vascular causes include torsion and varicocele. And immunologic like anti-sperms antibodies all are responsible for testicular causes. In a post-testicular causes, we understand post-testicular means is something related with vas deferens, ejaculatory duct problems, etc. So the epididymal causes, the vas deferens causes like congenital absence of vas deferens, Young syndrome, tuberculosis, in congenital cystic fibrosis, history of vasectomy, bladder neck surgery, retrograde ejaculations, all are related with post-testicular causes. If we come to the evaluation, which include history, examination, and investigation part, yes, of course, history is extremely important. Whatever causes we have discussed, we have to rule it out by detailed history and detailed clinical evaluation. In the history, the age is extremely important. By increasing age, there is definitely a decrease in the sperm volume, motility, morphology, but the concentration remains unaltered. Duration of infertility, history of childhood problems, especially undescended testes, mum porcicitis are responsible for infertility, and you have to go into the details of this type of history. History of tuberculosis, leprosy, allergy, Chronic respiratory disorders, you have to ask in conjunction with considering Young syndrome, cystic fibrosis, and Carter syndromes. Endocrine disorders, you have to see diabetes, hypothyroidism, hyperprolactinemia. You have to go into the details of sexual history, what is the coital frequency, whether desire is there or not, whether the satisfaction level is there or not. Occupation stress, nowadays in this era, the stress is extremely important and is one of the leading cause of sexual problems as well as male subfertility. Addiction of tobacco, alcohol, BD, and any gutka, and all these things are, we have to go into the details of all this history. Physical examination includes BMI, look for the obesity. Secondary sexual character, distribution of hair is extremely important. Go for an examination of breast, even in male, to rule out gynecomastia, galactorrhea. Always see thyroid glands. See the abdominal examination, do the abdominal examination, look for a lymph node, look for any scar or hernia, look for any abdominal lump. And yes, one of the important examination is the local examination, which include the organ like penile length, penile shaft. You have to see the scrotum for the rugosities, presence or absence of any hernia, hydrocele, varicocele, hypospadiasis, phimosis in the penile things you have to see. You have to see the presence and absence of the testes, the volume of the testes. And PR examination is also important in elderly age group to rule out the prostate and to look for the seminal vesicles. In investigation part, one of the important investigation is husband semen analysis. Total volume should be more than 1.5. These are the lower reference limit given in standard textbook. Concentration minimum should be 15 million per ml. 39 million per ejaculum is in ejaculum, and this is in ml. Progressive motility minimum 32%, but total motile sperms should be more than 40%. What is important is the morphology. 4% of normal morphologically normal sperms are able to produce a good fertility. What is important in semen collection method is there has to be a sexual abstinence of minimum 3 days and not more than 7 days, and it has to be obtained by masturbation, ideally near to the laboratory, collected in a clean, dry, sterile, white plastic mouth container, and then should be handed over to the laboratory person. A first sample, if abnormal, the another semen specimen should be collected at least 4 weeks apart to go to some conclusion. In physical examination of semen, we have to see the appearance, the viscosity, the volume, the pH, as well as the microscopic examination, which includes the motility. Yes, grade A is progressive motility where the sperms are moving straight. Grade B is something where the sperms are moving progressively but moving in one direction, in another direction. Grade C are not moving but they are viable sperms and they are just showing the flickering movement at their own place, or sometimes there can be a immotile sperms but viable sperm, and you have to rule out this, differentiate between the immotile sperm as a dead sperm or a viable sperm by using this eosin Y stain. So the normal sperms doesn't take up the Y stain, eosin stain, while the dead sperms stain pink with the eosin stain. Concentration technique, you have to see the sperm count, you have to label them as so many million sperm per ml or per ejaculum. Oligospermia is something where the sperm count is less than 15 millions. Mild to moderate is 5 to 15 millions per ml, and severe is more less than 5 millions per ml. Azu, when there is no sperm in the semen. Common causes of obstructive azoospermia, non-obstructive azoospermia. Obstruction, where there is post testicular causes, and non-obstructive are mostly testicular causes. Morphology, sperm morphology is extremely important and it should be seen. You have to rule out the abnormality in the head, the mid part, in the tail, and this is how commonly you can see, and the good laboratory definitely make a note on the abnormal shape of the sperms, abnormal head, chromosomal abnormality, mid piece abnormality, and tail piece abnormality. Another important test to differentiate between the obstructive and non-obstructive azoospermia is fructose test. If fructose is positive, that means non-obstructive causes, or an absence of fructose lead to obstruction at the level of vas deferens. Semen analysis terminologies, if we go normozoospermia is absolutely normal parameter, oligo is low, astheno reduced sperm motility, teratO is abnormal forms are high, and all FA are included in OAT syndrome. This aspermia is no ejaculum, while necrozoospermia is all non-motile sperms. hyperspermia when the volume is more than 5.5, and hypo is when the volume is less than 2 ml. Endocrine evaluation, FSH, LH and free testosterone hormones. In hypogonadotropic hypogonadism, FSH, LH are low as well as free testosterone. While in case of testicular failure, FSH and LH are high, while it has got a low or almost lower side of normal values. Other important hormone are TSH, prolactin to be evaluated. Genetic evaluation are indicated where there is a congenital absence of vas deferens or where we are suspecting cystic fibrosis, Klinefelter syndrome, and Y chromosomal anomalies are commonly associated with defective spermatogenesis. Ultrasonography, especially transscrotal inguinoscrotal area, is important, and in selective cases you have to go for a transrectal ultrasound, especially to rule out the presence or absence of vas deferens. Testicular biopsy, very few cases are indicated where the FSH values are high, and especially to rule out the non-obstructive azoospermia with normal FSH. Certain specialized tests are available. CASA, acrosomal reaction, biochemical test, DNA fragmentation index is one of the important index. In nowadays we are using a lot of this type of index to rule out male factor of infertility. And the commonest category is idiopathic, where we don't know what is the cause. If we go into treatment, assurance, counseling, empathy are the important part of this male infertility evaluation and management. You have to you have to see the weight, you have to ask them to reduce the weight. Lifestyle changes is another important aspect. They have to stop the smoking, you have to stop alcohol and any addictions. In cases of pre-testicular failures like hypogonadotropic hypogonadism, there is a definite role of HCG hormone. Low doses of HCG can restore spermatogenesis if we can detect these patients at an early stage. If HCG is failed to stimulate the spermatogenesis, then we can use HMG or pure FSH to stimulate the spermatogenesis in hypogonadotropic hypogonadism. In cases of hyperprolactinemia, the treatment is very simple. Cabergoline is the drug of choice. In hypergonadotropic hypogonadism, the only treatment option is donor sperms or adoption. In testicular causes, if there is anti-sperm antibody, IUI is one of the best method to overcome these anti-sperm antibodies. Leukocytospermia, a good course of antibiotic can definitely cure this type of problem, and retrograde ejaculation can be easily treated with certain drugs like imipramine 25 mg twice a day or 50 mg at bedtime can relatively improve after ruling out all the other causes of retrograde ejaculations. Erectile dysfunction, yes, of course you have to rule out psychological causes, upper system causes, but the sildenafil or tadalafil or newer drugs which are available can overcome with the erectile dysfunction. Commonly named preparations are Viagra, is sildenafil. Post-testicular, where there is an obstruction, what you can do is like surgical options are available where you can retrieve the sperm by microsurgical epididymal aspiration, percutaneous epididymal aspiration, or testicular sperm extraction. You can just take the sperm from the testes, use them for ICSI and overcome this type of problems. Other options are vasostomy, vasoepididymostomy and various surgical methods. Yes, of course, varicocele repair, orchidopexy are other ways of treating the testicular problems. Orchidopexy is specially indicated where in an infant of between 3 months to 1 year of age. Varicocele surgeries are indicated in grade 3 varicocele, and where grade 2 varicocele with low sperm count and not responding to the medical line of treatment, surgery is to be considered as one of the treatment options. Thank you so much for your patient hearing.